start sharing the slide. Can everyone view my slide at all?
No.
Oh, what's happened? Okay, one more time. Somehow my slide share is not working. You see.
Oh.
Okay, I think this one. Yes. So,
Yeah.
can you see now? Yeah.
Yeah, yeah, we could.
Sorry for the bit of glitch earlier. So, good morning, everyone. My name is Suraj, and I'm presenting the journal club for the article that's a meta-analysis, modified Valsalva maneuver for treatment of supraventricular tachycardia. And so basically, just wanted to touch base upon what exactly is a systematic review and meta-analysis. It's always a bit of confusion to start with, so I just wanted to clear that confusion. Systematic review is basically answers a defined research question by collecting and summarizing all the evidences, and that feeds the previous pre-specified eligibility criteria. So we're looking at mainly the evidence part of it. But the meta-analysis is the research process that's used to systematically synthesize or merge like multiple single independent studies to using the statistical methods to calculate an overall and absolute effect. Basically, let's say, for example, 10 of them, one by one, and to kind of add that up using a statistical method to come with a proper conclusion, overall absolute effect. Let's go with the article first. So this is the snapshot of the article. Basically, the top part, as you can see, it's one of the American Journal of Emergency Medicine 2021 that was published on. And if you come to the subject itself, a modified Valsalva maneuver for treatment of supraventricular tachycardia, a meta-analysis. Kinsao Lan et al. Has prepared this meta-analysis. And this was mainly, if you look at the A, B, and C part, this was mainly done in Lanzhou University, China. And it is accepted, if you look at the far left, left-hand corner, 24th of August, 2021, this was accepted. And main objective is what I've highlighted so far. The objective is to explore efficacy and safety of the modified Valsalva maneuver in SVT compared with the SVM is a standard Valsalva maneuver. So this is what the acronym will use throughout the presentation. And in the conclusion, basically, compared with the MVM, the conversion rate of SVT to sinus rhythm was more effective than SVM. And further, MVM also reduced the use of antiarrhythmic measures and drugs and had no increased time in ED and adverse events. So let's go further. So objective of this meta-analysis is, as we mentioned earlier, to explore the efficacy and safety of the MVM to terminate SVT compared with the simple vagal maneuvers. Sorry, it's also called Valsalva maneuver, but here it's written vagal maneuver to provide evidence-based medicine. So these are the inclusion criteria. Basically, the patients, all patients with SVT, intervention, modified Valsalva maneuver, straightforward. Control is simple Valsalva maneuver, simple standard Valsalva maneuver. Outcome measures is a success rate of achieving sinus rhythm. That is the final outcome. That can happen in 3 different scenarios. Basically, after single Valsalva maneuver only, or sometimes with multiple Valsalva maneuver, And the second one is use of antiarrhythmic methods after Valsalva maneuver. And the third one is the rate of adverse effects. So these are the outcome, basically. The study types that is included is the randomized controlled trial, regardless of whether the allocation, concealment, and blinding methods were used. The exclusion criteria basically falls under duplicated publications, comment letters, editorials, animal studies, case reports, and sometimes the incomplete or wrong data. There's a small like a flow chart that goes through that explains everything. Just to touch base upon the introduction of SVT, it's the most commonest arrhythmia in emergency department. Major causes of, I would not say most common. Pathological causes is in the bundle of His and above. Resting atrial rate or ventricular rate is more than 100 BPM, can cause fatigue, dizziness, headache, chest distress, dyspnea, and sometimes can endanger the safety of patients. There's a high chances of stroke, almost twice than the healthy adults. Sometimes it can come as a hemodynamically unstable patient. So in those cases, we need to do electric cardioversion. And in this article, basically the antiarrhythmic measures that they are saying is mainly the electric cardioversion. They haven't specified, but this is what specified in the reference section rather than the particular article itself. The hemodynamically stable patients would go for either Valsalva vagal maneuvers, the first line to stimulate the vagus nerve. These are the introduction for SVT. So the key points of modified Valsalva maneuver, which is the actual experimental kind of intervention that is done in this meta-analysis, is the patients are in semi-recumbent position, like basically sitting position, taking a 10 ml syringe, which is at pressure about 40 to 40 millimeter per mercury. And basically what the patient would do is on the side where the injection comes out, the fluid comes out, he blows from that part and push the plunger through, so as much as he can. The patient blows it for 15 seconds. And immediately afterwards, the patient is put in a supine position and his lower extremity raised to 45 degrees and maintain that position for about 45 seconds. That is the key points, basically. So here's the demonstration, quick demonstration. Let's go for it. As you can see, there's a reversal of the SVT to sinus rhythm, and the number came from about 200 to 68, 74. Right. The search mechanism that was used was mainly used PubMed, Embase, Web of Science, and Cochrane Library from the conception, basically, whenever the PubMed was started, Embase or others started, to June 2020. So basically, it encompassed the whole lot of it, what was available until the June 2021, which is a good thing that they did. They use the term supraventricular tachycardia, supraventricular, PSVT, SVT, paroxysmal supraventricular tachycardia, Valsalva maneuver, Valsalva maneuver, Valsalva. So basically, this is how they searched in the PubMed, Embase, Web Science, and come up with significant number of articles. And after that, they checked the articles reference list to the relevant publications. And there are two investigations that reviewed each one for the title and abstract screening. and one for the full text reviewing, and the third investigator actually adjudicated any disagreement with the search part. So here we can see this is a flow diagram of study search and selection process. So if you're on the left side, if you can see identification. So they've identified through search mechanism how much they have identified is 245 articles they have found out. On the right hand side, additional records identified, there was none, so n equals 0. If we come down the arrow, basically records after duplicated excluded. So duplicates were excluded, so they found almost like 100, about like 90 plus were duplicated. So they excluded that. That means like on the left hand side, if you can see, it's a screening process. And further, records excluded based on evaluation of title and abstract. So basically the title and abstract did not coincide with what they were searching for. So 130 was even excluded from that. So we're left with 28 now. If you see the eligibility is 28. From that 28 itself, they took out like full text article with reasons. There were n equals 22, review articles n equals 1, case series, because that is not the actual study that they're doing, expert commentaries, irrelevant studies, so all minused out. Basically only 6 were included. So as you can see, it's like quite a significantly kind of churned down process in here. So them only 6 remained. So out of those 6, 603 went into SVM group, which is what in here mentioned as a control group, and 605 remain in the MVM group, which is modified Valsalva maneuver, which is the intervention that is being done. The total patients are 1208. This is how the studies look like. So we're like 6 studies, as you can see in the table. Applebaum from Britain, Chen from China, Seelan from Turkey, Karbasioglu from Turkey, Wang from China, Yusuf from Egypt. So all that together, as you can see in the experimental group part of the table, and on the right hand side, the control group part of table, the numbers are almost similar. So they have actually measured against the similar sample size. Okay, this is just a snapshot of it. Go next one. So basically what we are trying to achieve is we're going through the cascade approach with using the CASP checklist. This is how we do the critical appraisal and related skills, and this is one of the best way to explain and kind of dissect out the articles. So from here onwards, if Patrick is ready with his presentation from 1 to 5, I want to pass it on to him, and I'll get back to you again.
Thanks, Suraj. That was great. Patrick?
I think Patrick is not hearing us, is he?
Yeah. So we'll wait for a reply of Suraj, what they are setting.
So how this Valsalva maneuver work?
Patrick is having issues with his computer. What I would probably have to do is to take his presentation in an email and probably start presenting. I'm sorry, guys, this happened. Shall I start presenting? The thing is, it won't come as a quite cascade, actually, if I do that. I have prepared some of the in a Word document. So if it's okay with you, Sarah, shall I start?
Yeah, do.
Yeah.
Yeah, whatever we can do. It's I feel sorry for Patrick, he's put effort in and we can't see him present now, but please do whatever you can.
Can you see my screen now?
Yeah.
Yeah, okay, so let's go ahead. So basically the CASP checklist is this one. So we're looking at A, B, and C. This is how we go down, basically. Just for someone who is doing journal club later on, it just doesn't make any like kind of night terrors or something. So we're starting with section A, which is what Patrick was supposed to present, but something happened, so he couldn't come with us. So did the review address a clearly focused question? I would say yes, because the focused question is mainly to explore the efficacy of MVM to terminate SVT in comparison with SVM. We're looking at this in the method section. So if I can move you to the method section, it might be easy. Sorry, I didn't actually prepare for this whole thing, but I have to switch back and forth. So if you go to the method section here, so we're looking at mainly the inclusion criteria that I've explained earlier. So the question was, did the review address a clearly focused question, and what was the intervention done, what was the population that was involved? So this is where we find out. So all the study subjects, all these were the area where we found out that what has been done to the subject, study, intervention, study type, the outcome measures that I've already explained in the previous slide. So let's move on to the other one. So the second question is, did the authors look like the papers? I would say yes, because they've included a significantly wide search strategy, and they have cut down to from 247 articles to they've cut down to 6 in number. So that included only RCT rather than anything else. So as you can see, as you can remember from this what I mentioned earlier, so they've actually dissected the whole lot to turn down to 6 RCT, and among them this is what I already mentioned as well: 603 in SVM group, 605 in MVM group. The overall experimental group received the MVM, control group received SVM. So there's one more thing that I want to mention is what's called a Jadad score. So basically, this is one of the ways they have actually made that quality scoring for the type of research they have actually searched for. So quality of the included study was evaluated by using Oxford quality scoring system, which is called Jadad scale. And based on that, they gave like a score of 3 to 4. The 3 to 4 scores were only included rather than 1, 2, or 0. So they did do some kind of randomization. They did do where do we look at the randomization? And everything is basically just over here. As you can see, data extraction and assessment of quality. So the quality part is mentioned right here in this part. So used the Jadar score, patient randomization, appropriateness of generating a randomized sequence, adequacy of adequate double-blind procedure, description of double blinding method, details of patient exclusion and dropout, all these were mentioned, and they were given a quality score from 0 to 5. Score more than 3 is regarded to be high quality and less biased. That's what they chose. And to sum up, this is the table that sums up, which I think I've got in the presentation here. Sorry for back and forth, but I'll just explain you in this. So it'll come in number 10 as well, but just briefly mentioning that this is what the Jadad scores for Jadad scale was like. I'll go back to the next one. Sarah, if you've got anything to say, please do.
No, I will. Don't worry.
Okay.
I'm listening intently.
Sure. Is it worth continuing? No, I'm not asking you, but it's the question actually. Do you think all the important relevant studies were included? I would say yes. Also, the same thing about the search criteria, the search words used, the library that was used, PubMed, Embase, Web of Science, Cochrane Library, up to June 21 from the conception. So this I've mentioned earlier as well, but I'm just going to touch base. 2 investigators reviews each title and abstract screening and full text review. The third one adjudicated any disagreements. The exclusion criteria were duplicated publications, comments, letters, editorials, animal studies, and case reports, and incomplete or wrong data, which I've already explained earlier. So move on to the fourth one. Did the review's authors do enough to assess quality of the included studies? Well, quality, I've just touched based upon the scale earlier, and the same thing, that's what we look into. And this I have already explained earlier. So if there was any disagreement, the third investigator would involve to reach a consensus. So basically, it's like a repetition of what I've said earlier. So number 5 question, if the results of the review have been combined, was it reasonable to do so? Here comes up part, okay, I need to type yes over there. Okay, so basically we're looking at the hint over here, because it is quite difficult just from the question itself what to look for. So hint says results were similar from study to study. Results of all the included studies were clearly displayed. Results of different studies are similar. Reasons for any variation in results are discussed. The whole thing is turned down to basically one particular word that is called heterogeneity, which is what is explained in one of the table later on. But I will just quickly explain you. Heterogeneity was low in this particular case results. So what does it mean? Hetero means, different, right? So if the difference is low, then the similarity is high. So almost all the data that is collected from the meta-analysis, the studies gave more like similar enough results that have achieved statistical significance. So to explain this, I'm going to just quickly show you the table and then move forward to the next. Okay, so if you can see right here, it says heterogeneity part right there. So we look at the I-square results as well. So I-square is a way of calculating heterogeneity. If it's 0, that means there's a low heterogeneity. That is what we expect. So if it's a homogeneous, that is what our final outcome should have been, which is right in this case. So I'm just going to explain a little bit more in this one. So sinus rhythm after single Valsalva maneuver, that is one group that was mentioned. But in this case, as you can see, there were only 1, 2, and 3 kind of article involved, not all the 6. Basically, as I mentioned earlier, the inclusion was single Valsalva maneuver or multiple Valsalva maneuver or single and multiple Valsalva maneuver. So as you can see, 1.1.1 is single, 1.1.2 is multiple, 1.1.3 is a single and multiple. So if you look at all these subtotals right here, 95% confidence interval, 2.83, 3.83, 2.85. So this is what we actually choose. The 2.85 is what we look at mainly. And the significance of the overall effect is what we look at the last. Because these are what we call a pooled results. Out of all three, that's the final pool results, which is right here, sorry, right there. Not this one, but this one here. So as you can see, so it's like a mantra in statistics. Any p-value less than 0.05 is statistically significant. In this one, as you can see, it's less than 0.05. This whole results are statistically significant. That's why we checked on the heterogeneity as well, which come out to be absolutely low. So statistically significant, low heterogeneity, good study outcome. So let's move on to the question itself, because if I go on to the 6th part, I can explain from my own presentation. Up to here, if you got any questions or do you want to comment on anything, Sarah? I'll just touch base upon the secondary outcome just after you comment.
Okay, yeah, no, you're absolutely bang on. I would say that there are 2 indicators for heterogeneity, and they're slightly complicated, but you're basically right to say that what they're looking for, they're tests to see if there is sufficient difference in either the results or the way the trials were structured or other factors that mean it's not a good idea to combine separate results into the meta-analysis. And the indicators that you pointed at are the I-squared percentage. So if that's 0, that means essentially there was no difference, no heterogeneity present. The other test is the chi-squared test, and it's the only one where the p-value is often set slightly differently. So if you can go back to the table that gives the p.
Right, so chi-square right here.
Yeah, so if you go, so
sorry, down here.
It is quite interesting actually. So you pointed on 1.1.1, the sinus rhythm after single VM. The I-squared result is 0. And the next one down, the sinus rhythm after multiple VM, the I-squared is 35%. Now that's still considered kind of on the low end of heterogeneity, but you can see that the 2, you could easily introduce difference if it doesn't say how many attempts at VM. So somebody might go into sinus rhythm after 2 attempts, 3 attempts, 5 attempts. There's variety there, and that is shown by some heterogeneity. There is some difference, but not enough to disturb it. The chi-squared test is I can't explain in massive detail, but the p-value associated with the chi-square test, they often set that at 0.1. It's not the 0.005 type thing.
Right.
It's a slight reverse. So if the p-value is greater than 0.1, there isn't heterogeneity.
Right.
So it's a bit of a reverse one, but those are the 2 tests for heterogeneity that would tell you if there was too much difference.
Thanks for your explanation, Sarah. Shall I move on then?
Please, yeah.
Yeah, okay. So as we've spoken earlier, so compared to SVM for SVT, MVM, which would be on the second slide, which I'll touch base upon in next slide of mine, regular presentation. I'll go back to my regular presentation now. I've finished Patrick's part of it. I'll explain you in more detail there. This one. Right. right. So we're using cost checklist, and this is the 6th question I've had. So what are the overall results of the review? If you're clear about the review's bottom line results, what are these numerically, if appropriate? How are these results expressed? NNT odds ratio. The comments look like I'm placing it blank, but I couldn't actually save it there, so I put it down below. Here the results are expressed in mainly risk ratio and mean difference, mainly the risk ratio, I would say. So out of the 6 RCT, I would just want you to focus on what I've actually colored. So MVM was found significantly to significantly increase the success rate of sinus rhythm after single VM. If you look at the confidence interval over there, it's not higher, but however, if you look at the p-value, it's quite significant. So we'll take that. That's what I've just explained earlier. Same thing with the after multiple VM. This is also statistically significant, and both combined together is also statistically significant, which is the pooled results. So another part is MVM also decreased the emergency antiarrhythmic treatments. That has also come out to be significant. As you can see, the p-value is less than 0.05. And use of adenosine and verapamil, p-value is less than 0.001. That means there was, after giving MVM, the chances of patient reverting back to sinus rhythm were higher. That is what is actually explained in there. There's also another results that we have is basically no significant difference in adverse events. There are several of them. I will explain in a while. Adverse events and the time in emergency department. So these had between MVM and SVM, there was no difference. So basically there was no conclusion that we can find out that SVM was kind of on the higher, like better side than SVM. It was like more of a neutral. So that's why statistical difference was not there. As you can see, the p-value is 0.11. That is kind of classic way to interpret. P equals 0.79 as well. So it's not less than 0.05. Right. Let's move on to the forest plot. So basically, this is a forest plot. I've just done a little bit of doodle over here. Let me bring this down. Okay. Right. As you can see, the axis over here, the x-axis is a favorable outcome, which is one side usually can be interchanged. So left side, you can see experimental, and right side is a favors control. So here the experimental is MVM, which is modified Valsalva maneuver, and control is SVM, which is a standard Valsalva maneuver. You can see the line of no effect that goes kind of perpendicular to this line. This is called line of no effect. And name of studies is seen on the right, on the left-hand side, which is X is econ, Y is this one. So let's say Rosenbaum et al, this one, Carla et al, this one. So basically the studies are on the left-hand side, and the same kind of studies are kind of stayed there as like a tree. Basically, this is called a forest plot. So it's kind of like called a globogram, like graphical display of estimated results from number of scientific studies addressing the same question along with overall results. So this is kind of, if you see this part is a kind of, this is like a mean of that study. If you see this study, this has not actually touched the line of no effect. This one actually does the line of no effect, meaning line of no effect. If it starts, then there is no effect. There is no outcome that you can actually find from there. But if there is not touched, then you can actually find some outcome. So a small dotted line down there, and the diamond here is the main focus. Basically, where exactly is the diamond? Is it touching the line of effect? Is it away from the line of effect? Is it going towards the favoring control side, or is it towards the experimental side? That is all this about. So the smaller the size of the diamond, the better the precision. The length total of this particular line in here, which represents a study, is equivalent to a confidence interval. Okay, so at the last, basically, the diamond is equivalent to meta-analyzed measure of effect, and its lateral point, which is this side right here and this one here, lateral points are the confidence intervals. So let's say, for example, the low range and the high range, basically. Yeah. So, and the last part to be explained is this particular number here. Sometimes it is written as 0, where it can be either mean difference or like, you know, more of a number x minus y, that comes out to be 0. That is how it's given. But if it's expressed in ratio, it is always 1. So that is how you determine whether it's a risk ratio or you're dealing with some like mean differences. I'll go to the next one. As you can see here, I'll just talk about the first plot now. Just change it this way. Right. As you can see, all being lined up on this side. You can see this is the precision of the result, which is just not touching the line of no effect. And this one also the same. And if you want to double check what I mentioned earlier, so this study I'm focusing, if you go all the way towards the left side, it represents Wang 2020, the results of Wang 2020. And the next one, Applebaum 2015. So basically same like that. Yeah. So this one particularly, and this one here is touching the line of no effect. So basically, we couldn't get any inference out of it. So there's no effect as such. When it says line of no effect, it's touched, there's no effect. If you look down here, it involves the ratio. In this particular scenario, it's the risk ratio that is involved. The risk ratio is, however, explained in terms of if it's 1, then likely kind of it's a compared risk between both the studies. But in this case, as you can see, it's going above 1. So we can say new intervention is better, which is a good outcome, which is what we've introduced MVM. But technically speaking, this whole forest plot is actually wrongly placed, because the whole thing should have been on the left-hand side. Because as you can see, the experimental group that we have looked at is MVM, not SVM. So this one actually favors SVM, which is absolutely wrong, because if you look at the p-value on this side, value is significant for MVM. So this was one of the flaws that I found out in the study. So it was a bit of muddle for me to find out what exactly is happening, because risk ratio is explained differently, but the outcome is somewhere else. Having said that, I'll just explain you in a while, and let's go to the next one. Okay. So basically, most of the time, outcome is if it's 1. New intervention is no better, no worse. New intervention, no better, no worse. Then we actually tend to interpret accordingly. But here it was more than 1. So new intervention is worse, would have been a bad outcome. But this one is actually a good outcome, because the sinus rhythm has been achieved. If it would not have been achieved, it would have gone to the bad outcome. So that is why the interpretation should be on the good outcome side. New intervention was better, intervention was MVM. That's why it is significant. Okay, the same thing here. This time the forest plot is right. Okay, so if you look at the figure number 3, this is for the verapamil or adenosine after the MVM or SVM. So as you can see, the risk ratio, the diamond actually is quite small. And the confidence interval is very small as well. And the fact that the precision, because it has not touched the line of effect, it's quite significant. So, so new intervention is better in here. in the same thing in this particular chart, which mentions the antiarrhythmic treatments after VM. So this was better shown in MVM than SVM. That's why it favors experimental. So in this study, as you can see, the diamond is actually squashed in the line of no effect. Line of no effect means this does not give us any conclusion at all. So length of the stay in the ED, adverse events, which is also touching the line of no effect, we haven't got any statistical significance in that. As you can see, the overall p-value is 0.11 only, is less than 0.05. Same thing over here. Let's move on to the other one. This is what I've already explained earlier regarding all the figures. So we'll go to the next questions. How precise are the results? Same thing, kind of overview. If we look at diamond in the first plot, if it's not touching the line of no effect, results are precise. If it's smaller the diamond, the precise the results. The short the confidence interval, the better the results, which is the lateral points of the diamond we're talking about. This is number 8 question. Can the results be applied to local population? If you look at the hint, what does it mean by local population? Consider whether the patients covered by the review is sufficiently different to your population to cause concern. Your local setting is likely to differ much from that of the review. So how do we check the application to local population? Is basically, I feel the results can be applied to local population. That's why I put it as a yes. As MVM needs less expertise and can be done in any settings, even in one of the places, patients with SBT and emergency doctors using MVM at home or in ED can quickly and safely terminate the onset of SBT. So basically, they have talked about doing this at home as well. So that's why it can actually be applied to a local population as well, if they are like a slightly experienced in terms of how to do this maneuver. It's better if there are medically trained people around, and better if it's nearby the hospital. So if it doesn't work, then we can always bring them to the hospital. The study involved 5 countries: Britain, China, Turkey, China again, and Egypt. So I think it was duplicated there. Sorry about that. 4 countries were included. So based on this, we could actually look into the British population, which is our local population. However, there are a flip side to it. Population with SVT who might have thyroid disorder can be recalcitrant to any maneuvers like what we mentioned so far. So MVM may not be of any help. There's another further argument which we can make regarding the study size of this particular study. It's 603. It's quite small. So this gives us a less power to look into whether these results can be accurate or not. But regardless, if we look into the whole scenario, the local population can actually benefit from these results and can be applied to them. So the 9th question, am I going too fast?
No, you are okay.
Okay, yeah. So were all the important outcomes considered? So if there is other information that you would like to have seen, not all the important outcomes were considered. Basically, those 2 that were explained in primary outcome, which is success of achieving sinus rhythm, which is the motto of MVM. Secondary outcomes were also included. However, the worsening of arrhythmia that might need ablation, maintenance of the euthyroid state, these were not addressed. And the fact that antiarrhythmic measures is the only terminology that is used in the whole article, and it does not encompass anything like electrocardioversion or any other measures. So it is kind of not fully understood whether they actually want to involve just the cardioversion or there are any ablative methods they wanted to look at. So this is why the outcome consideration could have been more encompassed based on the anti-arrhythmic measures, name of those measures. As I've explained earlier, the adverse events that happened during the process, as you can see in the secondary outcome, it was commonest one was dizziness after the Valsalva maneuver, and some of the rare ones were nausea, chest tightness, skeletal muscle pain, headache, and basically these were the rarer adverse events that has happened. Moving on to the last part of it, are the benefit worth the harm and costs? I would say yes, because definitely the MBM it achieves sinus rhythm in SVT patients, and it's likely to cut the cost of adenosine, verapamil, any anti-arrhythmic measures, along with the medical burden of the patient, using up the beds, consuming other medical resources as well. The cost itself has not been discussed in the article in any part. The funding, it says none. So for MBM, we don't actually need any particular funding. So it is a procedure that is done clinically. So that is probably the reason why they haven't actually explained about it. The whole cost and benefit part of it can discussion section, as I've highlighted over there. Success rate of achieving sinus rhythm in patients with MBM. Side effects were dizziness, no cardiac adverse effect, events. So even this is the part I was explaining earlier. So basically, even the emergency doctors and patients with SVT, they can do MVM at home or in the ED and can quickly and safely terminate the onset of SVT so as to reduce the medical burden of the patient and the consumption of medical resources. So these were the results which I've already involved in my previous slides. So however, we're talking about the limitation part of it. This doesn't fall under any part of questions, but I feel like we need to actually look into the limitations as well. So as we specified earlier, that the sample size was quite less. The sample of the study is relatively small, so it's hard to kind of accept the statistical power and get the accuracy of the results as well. Second thing is there's no standardization. As I've explained, I've played in the video earlier. So each clinician has their own way of doing MVM. In case of Applebaum, which is one of the articles that we've looked into, one of the RCT that we looked into, this is the British RCT actually. So he mentioned that to patient blow a 10 ml syringe from the kind of front side and then do it for 15 seconds. However, the Turkish one, which is Sealand one, mentioned it blows for 20 seconds. So in addition, the same Applebaum article explains patient to be in a supine position first and raise the lower limb to 40 to 45 degree when the maneuver is actually being done after blowing the syringe. But in some other studies, it mentioned that lower limbs were elevated to 90 degree rather than 45 degree for the same amount of time. So the exact standardization could not be done because these were the study happened like after several years, and this was more of a meta-analysis we're doing. But these are the limitations that we found out from there. And the third one is it did not actually explicitly mention the random sampling method. Also, the allocation concealment, which is like how did we kind of allocate the patients to MVM or SVM, that was not quite well mentioned. And this could have caused selective bias and implementation bias in the trial. Some data like length of stay in ED is very hard to find out using mean and standard deviation. So they used something called a method of HOSO to use for numerical conversion that may also affect the accuracy of the results. So the table itself in here, as you can see, the MH fixed on this part right here, that is what the method they used. it is just to understand if it come across like next time. So just to have a better understanding. But here it is. Here are my references, the main article itself, and I went through this YouTube video. It's quite brilliantly explained, and I think that helped me a lot to get with the meta-analysis part of it. So thank you very much for listening. I hope I haven't gone more than what the time gave me. So if I put so is it okay, Sarah, if you take the lead now and then give us feedback or anything that is remaining?
Sure. You had a very difficult job to do there.
Yeah, I'm sweating at the moment, to be honest.
You're sweating. It was a paper that looked really quite straightforward on the surface, and they found very convincing results. It was very, very clear that the modified Valsalva maneuver came out tops. And yet the forest plot had got it completely reversed. I want to know what you do with that. The fact is, this is a paper that's been peer reviewed, it's published, and yet the forest plot is not right. It is completely back to front. So the detail that allows you to interpret the paper is in the text, not that visual representation. You're supposed to be able to rely on the forest plot. And it's because they approached it in a standardized way that results on the left favor the experimental, results on the right favor control. And that's a very standard layout. But it takes away from the fact that what you need to bear in mind is, what is the outcome? What are they actually looking for? Is the outcome a good outcome, or is the outcome a bad outcome? And it makes an entire difference how you interpret the risk ratio. So in that little table that showed, which I'm going to stick into the WhatsApp chat, so you've all got this quite a kind of detailed handout that you can have a look at. It helps interpret the risk ratio in relation to the actual outcome, whether it's greater or lesser than 1, i.e. goes to the right or the left of the line. It's absolutely crucial. You need to bear that in mind too. Oh, you're going to find it for me. That's excellent. That's the one. So it isn't as simple as left is good, right is bad. It entirely depends on how you interpret the risk ratio as to whether you're looking at a good outcome, as in reverting to sinus rhythm, or a bad outcome, needing additional medication, for example, the adenosine, or what else did they use for Apamil? So if you needed extra medication, that's bad. If you revert to sinus rhythm, that's good. And that helps you interpret the risk ratio. So Suraj, thank you for having a really good stab at that. It was not easy, and you don't expect to review a paper and say, actually, they've presented it entirely wrong, but they did. So I'm happy if you want to move on to the next, or whether you want to.
Thank you so much, Sarah.
Anything else anyone else to come back on that? A final complicated thing.